recognizing and taking care of tumors. The T cells are considered to be the immune cell that provides for surveillance of cancer cells. Cancer cells, some ways that the immune system can find them is that cancer cells display what's called tumor-associated antigens, or TAAs, on the surface. So our immune system, specifically our cytotoxic T cells, are roaming around looking for those TAAs, and that's how they can recognize it's a cancer cell. And when they do, then they'll attack it, okay? There are other immune components in the response. They include things like macrophages, natural killer cells, and B cells, okay? Typically, for most of the time, our normal immune response is adequate to prevent the mutated cells to progress on into cancer cells. Because remember, one cell is not going to be cancer. We have to have that proliferation, okay? There's a pretty good discussion in your book about the immune system, okay? There's a variety of methods that we utilize in order to impact from an immune status. However, cancer cells are also, as I say, very smart, and they can use a variety of methods to avoid the immune system finding and destroying them. They can actually produce factors that will suppress the immune system. They can also suppress the production of T cells. On the surface, the TAAs of the cancer, over time, they can kind of weaken so that the cancer cells are less visible, so to speak, to the T cells. They can also develop a tolerance to the immune system, to some of the cancer antigens. They can produce suppressor T cells to actually shut the immune response off. And they can produce antibodies that specifically block so that the T cells can't recognize the cancer cells. This slide talks about the progression of cancer on a very local level. And this slide talks about invasion. This is whenever you have a tumor cell that moves not through the lymph or through the blood, but moves adjacently. And the way that it works is that the tumor causes pressure atrophy and necrosis of the adjacent cells. And then once that necrosis happens, the tumor will grow into that necrotic area. Eventually, it'll disrupt the basement membrane of the normal cells. And then we'll have excretion of enzymes that actually degrade the physical barrier so they can move into the normal tissue, and they can actually then work their way down into the blood or lymph, okay? So cancer cells exhibit something called motility, and that's because cancer cells are less tightly bound, so they can easily separate from the neoplasm and move into the surrounding tissues and fluids. They also will respond to chemical signals from adjacent cells. This is called chemotaxis, chemotaxis. This is whenever there's a chemical stimulus that kind of calls to the cancer cells, and they'll move over towards that, okay? There's something specific to cancer cells called an autocrine motility factor. Autocrine, AUTOCRINE, motility factor. This is actually a substance that some cancer cells produce that calls other malignant cells over to the normal tissue. What happens is the first invading cells go into the normal cells, and then they produce this substance, and it actively signals over and draws other malignant cells from the primary tumor over into the new area of invasion. We also can have cancer spread through blood or lymph-borne metastasis, and this allows the tumor to be established at a distant, or sometimes we call this distant metastasis, okay? In order for the elements required for us to have blood-borne metastasis is they have to have intravasion of the malignant cells through either the blood or the lymph, so they have to be able to the blood or lymph vessel wall and get into the circulation. The next slide shows you a picture of this. Then, as they travel through the blood, they have to be good at avoiding the immune system. And then as it travels through the blood system, then it'll find a spot where it wants to get out of the blood vessel, and it does something called privation, and that's when it attaches to the inside wall and then eats its way out. Okay? Let's see if there's anything else I really want to say about that. Probably not. Okay? This is just showing you a picture of what I talked to you about. Okay? What happens is that when they move, after they eat their way into the blood vessel, then they go along. What tends to happen is they tend to clump together, and after they clump together enough, that's when they'll form an embolus, and then they'll travel until their size prevents further travel. And when their size then kind of prevents further travel, that's when they'll fall against the wall of the vessel and eat their way out. Okay, and where they eat their way out and land is where it's going to be the site of the distant metastasis. Okay, classification of cancer. I've given you different aspects of the way that cancer can be classified, and I'm going to talk about them more in following slides. Okay. In general, I want you to know that classifications can be a tissue or cell of origin. Grading evaluates the amount of differentiation and aggressiveness of the tumor, and staging is used to classify solid tumors and refers to the size and extent of the disease. The anatomical classification, you can see a table for that on page 254. I'm not going to go into detail, and I'm also not going to test you on the anatomical, okay? Histological, this is also on page 254, and it talks about the level of differentiation of cells, okay? And it does a good job of outlining that for you in that page of 254, so you can look at that page. I'm not going to talk it through with you, okay? Okay, staging. We can have clinical staging to determine the extent of the malignant disease by using different stages. Clinical staging is done after the diagnostic workup, and it's used to determine the treatment plan. So we've got stages 0 through 4, okay? There's a couple of examples in your book that are not in the cancer chapter, okay? So if you want to see staging with an example using cervical cancer, go to chapter 54, I think it's table 11, or for Hodgkin's lymphoma, figure 14 in chapter 31, okay? So I'm going to walk you through here. So stage 0. What a stage 0 is that cancer is in situ, okay? And in situ is the word in, and then the word situ, S-I-T-U. This is a tumor that's confined to its original site of origin. It's not invaded even any neighboring tissue, okay? It's not gone anywhere. It's just staying home, so to speak, okay? Stage 1 is whenever you've got the tissue, it's limited to the tissue of origin, but it does have localized tumor growth. Tissue 2 is where you see limited local spread. Stage 3, I think I just said tissue all the way through there. Stage 3 is where you've got extensive local and regional spread, and stage 4 is metastasis, okay? So I want you to use your book, and I want you to look at those examples. I do ask you test questions about the stages, okay? So you can have, just understand that that's something that you do need to know. I also ask you about the Tnm scale. This is an internationally recognized scale that's utilized. I give you some information on the slide, but I'm going to go ahead and tell you a little bit more. For Tnm staging, T is the extent of the primary tumor, N is the absence or presence and extent of regional lymph node metastasis. And metastasis is pretty simple. It's either the absence or the presence of distant metastasis. So, looking at T, primary tumor, T. TX, that means the primary tumor cannot be assessed. What might that be? Like a leukemia, for example, there's no tumor, so you can't assess it. T0, there's no evidence of a primary tumor. TIS means that there is a tumor, but it's a carcinoma in situ. We just talked about what in situ meant. Then T1, T2, T3, and T4 all have to do with the increasing size and local extent of the primary tumor. Okay, so if I told you that a tumor was 1 centimeter, that would be like a T1. Okay. Regional lymph nodes, NX, means that the regional lymph nodes cannot be assessed. N0, no regional lymph node metastasis. N1, N2, N3, increasing involvement of regional lymph nodes. So let's say I told you that there were 2 or 3 lymph nodes that were affected. That would be like an N1, okay? Then N2 or N3 would just mean more and more lymph nodes are involved. But remember, we have a lot of lymph nodes in our body. So sometimes students get confused and think that N1 means that there's only 1 lymph node involved, and N2 means that there's only 2 lymph nodes involved. But that's not the case, okay, because we only have N1, N2, and N3. So N1 means a very small number. So again, if I told you that 1 or 2 or 3 lymph nodes were involved, that would be an N1, okay? If I told you 20 lymph nodes were involved, that would be like an N3. Then as far as the M, all the M has to do with is the distant metastasis. Again, we either have it or we don't have it. So an M0 means there is no distant metastasis. An M1 means that distant metastasis has occurred. The only little fly in the ointment there is MX, and all that means is that we cannot assess whether or not distant metastasis has occurred.